Perfect. All right, so this is Dr. Alan Wein. He received his undergraduate from Princeton, medical degree from the University of Pennsylvania, did most of his training there in surgery and urology at the University of Pennsylvania, was awarded an honorary PhD from the University of Patras, and also he was named the Founders Professor in Urology. So it was just recognizing or in recognition of Dr. Wein's many contributions in the field of urology. He's received numerous awards, as I was explaining before, in urology, including the Distinguished Service Award and Distinguished Contribution Award of the American Urologic Association, and a whole bunch of literally lifetime medals, the Edward Keyes Medal, among others. He's also the editor-in-chief of the most recent editions of the Campbell-Walsh Urology. And the textbook was actually changed to Campbell-Walsh and Wein Urology to reflect his many contributions to the field. So everybody, I just want to introduce Dr. Alan Wein to give his talk.
Thanks so much. It's a pleasure and an honor to be able to do this, so I appreciate it. I hope that the weather down there is milder than it has been in South Florida. Anyway, I got back from South Florida yesterday. My flight was actually canceled, so I got up here by a somewhat circuitous way. What I'm going to talk about today is Nocturia and try to give an overview, an update, and what the state of the art basically is with respect to Nocturia now. So what is Nocturia? Can everyone hear okay? Is it coming through all right?
It is on my end.
Okay. Yeah, Alan, keep going, Alan. I'm going to try to fix the volume on my end, but go ahead and keep going with your talk because we can hear you.
It's yeah, this says set up professional audio in audio settings. I'm not sure exactly what that means. So I'm going to click that. So anyway, what is Nocturia? Well, a practical definition is getting up at night because of the need to urinate. Now, there have been all kinds of definitions of Nocturia that are a little fancier than that. ICS means International Continence Society. So the original definition was waking at night one or more times to urinate, each urination preceded and followed by sleep. It's been changed a few times. The current definition, as approved by the ICS, which is sort of the repository for all terminology standardization for lower urinary tract function. So the current definition of Nocturia is waking to pass urine during the main sleep period. It must be followed by at least the intention of getting back to sleep. So in other words, getting up in the morning, urinating, and not intending to go back to sleep, that's not Nocturia. So the first morning void after a night's sleep, the episode is not counted in Nocturia. It's counted in the diurnal and daytime frequency, but the volume, because that volume was excreted overnight, is counted in the nocturnal voided volume. So the issues regarding Nocturia are these. Number one, it's really an unstudied phenomenon or understudied. It's also undersought after and under-recognized as a real standalone program. You'll see shortly that it really is the most bothersome, assuming that you wake up 2 times or more, the most bothersome of any of the lower urinary tract symptoms. It's not really a natural part of aging. It's not a disease of only the elderly. It's not just due to overactive bladder in women and benign prostatic obstruction in men. And it does, as you'll see, have very adverse effects on the quality of life, and you'll be amazed to see that it's associated with a decrease in the quantity of life as well. So these are the questions that hopefully I'll be able to answer. Why does it occur? When does it become bothersome? Why is it important? When is the waking episode most bothersome and harmful? How common is it? What's the prevalence? What are the contributing factors and causes? And how can you successfully manage nocturia? So, why does it occur? Well, having to get up at night or not because of the need to urinate is simple. It's a product of the relationship between the amount of urine produced at night and the ability of your bladder to store urine. The ability of the bladder to store urine normally at night, and so permit you to sleep through the night without getting up because you have to urinate, depends on these factors, which are all pretty simple. Maintaining a low pressure inside the bladder during filling, that's called compliance. Having normal sensation as the bladder fills. Not having any involuntary bladder contractions, otherwise known as bladder overactivity or detrusor overactivity. Having adequate sphincter function so you don't leak at night. Having an adequate bladder capacity, in other words, your bladder holds an adequate amount of urine, and when you empty, you have near complete emptying, because if you don't, if you have an elevated residual urine, then obviously your bladder capacity, your functional capacity is going to be decreased, and you're going to have to urinate more frequently. And finally, and maybe most important, no excess urine production at night. So when does nocturia become bothersome? Because bother actually is not a part of the current definition. Everyone pretty much agrees that if you get up 3 or more times a night because you have to urinate, it's a moderate or serious bother. And most people, not all, agree that if you get up 2 or more times at night, that it's at least moderately bothersome. And if that represents a significant change from your usual way of conducting your day and night, then that can be seriously bothersome as well. So nocturia is in fact the most bothersome symptom in patients with LUTS, lower urinary tract symptoms, and BPH, benign prostatic hyperplasia. It has a significant impact on the quality of life. Now here we're talking about nocturia 2 or more times. Okay, not nocturia once, but 2 or more times. What's the most important part of sleep? Well, it's called the first uninterrupted sleep period, or FUSP. That's when the slow wave restorative sleep occurs, and lighter sleep occurs later on. So if someone wakes up during the first 3 to 4 hours after they go to bed with the intention of going to sleep for the night, that's much more likely to have or show the adverse effects of nocturia the next day than if they wake up later. So 4 hours is kind of the magic period for you to be able to sleep without interruption after you go to bed with the intention of going to sleep. So a single episode of having to get up to urinate in the first 4 hours is much more bothersome and has much more adverse effects the following day than if you have to get up for the first time in the second 4 hours. Now, there are many adverse associations with nocturia, and these are well documented. You see the references. Reduced health-related quality of life, HRQOL, mood disturbances, reduced work productivity, increased falls, increased fractures, probably because of the falls, poorer overall health, and as you'll see, interestingly enough, increased mortality. And the increased mortality goes up just as a function of the number of nocturic episodes. So this is health-related quality of life, very pretty slide. And basically what it shows in men and in women is that as you increase the number of nocturic episodes, you also increase the adverse effects on all of these composite qualities of life listed below. So everything gets worse. The more you get up at night, the more you have to get up at night. The short-term consequences basically consist of increased daytime sleepiness, reduced daytime alertness, longer reaction times. So if you're driving, longer reaction times, decreased daytime energy, reduced psychomotor performance, decreased concentration and memory functions and cognitive functions in general, and just kind of a lousy, poor mood. The long-term consequences, depression, increased susceptibility to somatic disease, and no one really knows why, increased risk of cardiovascular disease, increased risk of car accidents, increased risk of falls and fractures, and an increased risk of mortality. Now, because of the serious systemic diseases that nocturia is sometimes associated with, you might expect mortality to be increased because of these. However, exclusive of comorbidities, nocturia is associated with increased mortality. Now, this is nocturia 2 times or more, and I'll show you a few examples of this because it's pretty startling. So here's one, and you can see the difference between 1 time or less and 2 times or less. I'm sorry, 2 times or more in terms of percentage survival out to 40 months. Here's another one looking at nocturia once or less, twice, 3 times, or 4 times or more in terms of days. So you can see that, wow. And this particular study was adjusted for age, sex, weight, diabetes, smoking status, history of coronary artery disease, history of renal diseases, stroke, use of tranquilizers, hypnotics, and diuretics. So pretty impressive and still associated with increased mortality. Now, no one knows why, but it's definitely associated. This is the Nahane study from the US in both men and women for nocturia 2 times or more, and worse survival in a large population of men and women. It affects daytime activity and work productivity. This is a Swedish study. I'm not going to discuss the details, but take it from me that the details do show that there's a negative effect on daytime activity and work productivity. So it costs employers money. This shows that it's increasingly associated with sleepiness during the day, another Swedish study, naps during the day, and more importantly, the amount of sick leave that people take off. The more nocturia, the more sick leave they take off. So how common is it? Well, this is a pretty simplified graph, but the graph is actually accurate, and it's accurate for men and women. So you can see that a substantial percent of the population gets up 3 or more times at night, and 2 or more times at night, and 1 episode per night. 1 episode, I think you can disregard as far as adverse effects. But if you look at 2 and 3 and you add those up, it's a pretty substantial portion of the population as the population gets older. And the population obviously is getting older all over the world. So what was an average life expectancy 25, 30, 40 years ago is not an average life expectancy now. And if you think of the people that you know and your parents know, or if your parents are still alive and they have friends, et cetera, you can see that a lot of people are going to fall into this bar here and this bar here. So what are the contributing factors that we can identify for nocturia, and therefore maybe those things that will give us an easy fix by correcting them? Well, this is a very, very simplified diagram that, as you can see, is 20 years old, and yet it still works. Basic sleep disturbances, well, we as urologists and internists, family practitioners, are not going to be able to do very much about that. And psychological factors as well. Bladder storage problems, we can do something about. And polyuria, making too much urine at night. Polyuria, you can divide into nocturnal polyuria, just at night, which is obviously what we would be interested in, and 24-hour polyuria, that is making too much urine all day long, which is a different animal. And obviously you can have combinations of any one of these, or any two of these, or any three of these. So under primary sleep disorders and psychological factors, sleep apnea is the only category here that we can actually fix very well, although the fixing sometime involves a machine that unfortunately for CPAP winds up under the night table because it's kind of bulky and it's kind of uncomfortable for the partner who has to listen to those respiratory movements all night. Periodic leg movements, sometimes you can give a medication for, but basically these other factors are sort of not within our realms to treat unless you want to treat as a family practitioner or internist, depression and anxiety. Bladder storage problems are more familiar to the urologist or gynecologist. These can either be neurogenic, as with multiple sclerosis, or post-stroke, or spinal cord injury, or Parkinson's disease, or they can be non-neurogenic, in other words, with no apparent neurologic cause. You can have a reduced functional bladder capacity. In other words, the bladder just doesn't hold very much, or as much as it should. This can be due to an elevated residual urine volume, like you see in some patients with benign prostatic obstruction, or patients that have an underactive bladder. You can see it in detrusor overactivity, that is involuntary bladder contractions. You can see it in patients who have urinary urgency, which is defined as a sudden urge to urinate that's very difficult to defer. Now, these three we can usually treat reasonably well. Once a bladder becomes fibrotic and fixed, that's very difficult to treat. And any of you who have cared for patients that have bladder pain syndrome, otherwise known as interstitial cystitis or pelvic pain syndrome, know that it's very difficult to treat that. Other bladder storage problems can be associated with extrinsic compression on the bladder by a pelvic mass or by an enlarged uterus. Bladder outlet obstruction, like you would see in a patient that has BPH, decreased detrusor contractility or underactive bladder. If a patient has a stone that's impacted at the ureterovesical junction, that can cause increased frequency. So if nocturia comes on, well, like all of a sudden, and especially if it's associated with increased daytime frequency, you might just get a plain film or a limited CT urogram to see whether there's anything that's in the urinary tract, either in the bladder or in the distal ureter, that might be causing that. Lower urinary tract cancer, the effects of aging on the lower urinary tract. Obesity is associated with bladder storage problems. The jury is still out on whether estrogen deficiency is really associated with overactive bladder or any increased urinary urgency, and whether you can actually manage nocturia by giving estrogen supplementation or vaginal estrogen supplementation. There are many drugs that can cause nocturia. Probably the most common one that you'll see is lithium. It decreases part of the mechanism that's responsible for retaining urine. And so it's very common for many people that who are on lithium to have nocturia pretty much every night, and also some problem during the day. Calcium channel blockers can also do it. The selective serotonin reuptake inhibitors can also cause it, and of course diuretics, especially if someone takes their diuretic late in the day. One of the fixes would be to simply suggest to their family practitioner, internist, whatever, that they take their diuretic earlier in the day. They'll urinate more then and hopefully less at night. Central nervous system stimulants, some respiratory drugs, a lot of the psychotropics. I don't know if any of you have ever seen a case of ketamine toxicity. Ketamine is a popular drug overuse now, especially under young people. And it's a direct toxin to the urinary tract, much like cyclophosphamide or Cytoxan. And once the fibrotic effects of ketamine set in, it's really impossible to treat without mechanically enlarging the bladder. Now, polyuria comes in two forms. One is increased urine production all day long. We're not going to talk about that except for inadequate control. And nocturnal polyuria, which means that you just excrete more urine at night. That can be due to drinking too much fluid at night. It can be due to congestive heart failure. It can be due to any kind of peripheral edema. It can be due to obstructive sleep apnea. And it can also just be due to a defect in the secretion or action of arginine vasopressin. This is physiologically a compound that's secreted by the hypothalamic pituitary axis that basically goes up at night and is down during the day. So you should excrete approximately 2/3 of your urine during the day and 1/3 at night or less. And that somehow gets disordered. Less arginine vasopressin is excreted than normal at night, and you have increased urine output. So nocturnal polyuria is the overproduction of urine at night, and the conventional definition is over 33% of the daily urine volume. Now, polyuria, that is too much urine during the day, in a 70 kilogram adult, the average is defined as greater than 40 mLs per kilogram. So if someone is 70 kilograms, then obviously it's greater than 2,800 mLs per day. Nocturnal polyuria in older adults is defined as greater than 33% of the output. And in younger individuals who rarely have nocturia, it's defined as greater than 20% of the 24 urine output. So here's a question. Utilizing the 33% definition, that is, people who present with nocturia, how many of those do you think have nocturnal polyuria? That is, make over 33% of their urine during what should be the sleeping hours? 40%, 50%, 60%, 80%. Well, you might be surprised to see that it's over 80%. Now, that nocturnal polyuria, it may be due to something like congestive failure. It may not be idiopathic. It may not be due to an arginine vasopressin deficiency. But the point is that over 80% of patients who present with nocturia, if you measure their output during the day, if you do what's called a bladder diary, then you'll find that they have nocturnal polyuria by this definition. So these are a number of studies from Europe, from the US, and from Asia. Basically, you can see the percent. So it's somewhere between, let's say, 75 and 85%. So how do you evaluate a patient comes into the office and you're going through their review of systems and, why are you here? What bothers you? And you should ask specifically about nocturia because it is bothersome, but someone may figure, it's a part of getting old. I'm not going to say anything about it. So the first thing you should look for is what I call the big six, because they may not be totally correctable, but the point is that you can make those better. Excess fluid intake at night. How much do you drink between dinner and bedtime? Well, I usually have 2 or 3 beers. Well, obviously what goes in has got to come out. And so it's pretty easy to identify that if somebody is truthful. Poorly controlled diabetes. So it's important to have very tight diabetic control. Congestive heart failure, where basically you have a lot of interstitial fluid that's outside the vascular system. When patients lay down at night, all that goes back into the vascular system. It all contributes to renal blood flow. They put out more urine. Actually, peripheral edema due to any cause can do that. And so, one of the simple things you can have a patient do if they have peripheral edema at the end of the day is have them lay down for an hour, hour and a half, about 5 or 6 o'clock with their legs elevated as high as they can, preferably over the level of their heart. Patients who have what's called non-dipping hypertension. In other words, at night, your blood pressure normally goes down. If you're hypertensive, your blood pressure still should go down at night. If your hypertension is not controlled so that your pressure does go down at night, then that can be a contributing factor to nocturia. So really good control of blood pressure in a hypertensive individual, especially those whose pressure doesn't drop at night, can certainly be something very simple that you can do. And sleep apnea. Well, so to evaluate patients, it's very helpful to get them to do what's called the bladder diary or frequency volume chart. It's really simple. There are pre-made charts. If you look up frequency volume chart, on Google or whatever search engine you use, it'll show you one. You just mark off the time, basically how much you put out. The patient has to measure. You give them a container to measure their urine, or just tell them to use a measuring cup and just put it in the dishwasher when they're done. So they record the time of day or night, the amount. You can have them record how much they intake as well. They're not as good at doing that. You evaluate the patient for whether they have symptoms of overactive bladder or benign prostatic hyperplasia with obstruction. And you evaluate them for nocturnal polyuria. The frequency volume chart will give you the answer to whether they have nocturnal polyuria or not very quickly. And you're used to evaluating patients for overactive bladder, urgency, with or without urgency incontinence, usually present with urinary frequency during the day, and nocturia, getting up at night. So once you've evaluated the patient, and once you have a pretty good idea of what their contributory factors may be, then you can start to manage them. There are very simple behavioral suggestions that if you implement these, I guarantee you, you're not going to cure the nocturia. You're not going to make someone go from 3 to 0, but you may make them go from 3 to once, or maybe once every other night or something like that. There are some quick medical hits that I'll describe to you. If someone has overactive bladder and you're pretty convinced that that's responsible for their nocturia, that is that they have significant urgency when they get up at night and have to void. Not, someone who gets up and says, oh yeah, I have to urinate, I'm going to go to the bathroom. Someone who gets up and says, if I don't make it to the bathroom, I'm going to wet myself, that kind of person. BPH, if the prostatic hyperplasia is associated with obstruction and the obstruction has caused involuntary bladder contractions, then you can treat that. And especially if they have residual urine, it's going to decrease their functional bladder capacity. And so successful treatment of BPH can be helpful in the management of nocturia. And if all else fails, you can treat the nocturnal polyuria with a medication that I'll show you as well. So what are you looking for in terms of success? Well, obviously the number of nocturia episodes, but you're also looking for the first uninterrupted sleep period. And what do you want to get it to? You want to get it to 4 hours. The quality of life indicators, if you can improve these, trust me, the quality of life indicators will improve. Has anyone shown a long-term decrease in the adverse events that I've described to you with a lessening of nocturia over time? That is a parallel variation? Not really. So if anyone is interested in doing future studies on nocturia, that would certainly be one area to look into. Does in fact decreasing the nocturic episodes over a long period of time result in a lessening of those adverse outcomes? There's little question about improving nocturia, improving the health-related quality of life over the short term and over the long term. I mean, that definitely does occur. No matter what evaluation you use, what survey you use, that does get better. So this is an important slide. What are the simple behavioral and lifestyle modifications? Presumptive voiding or preemptive voiding. Urinate right before you go to bed, maybe urinate a couple times. Get your bladder as empty as possible before you go to bed. Preventing excess intake. In other words, between dinner time and bedtime, you should drink as little fluid as possible. If you have a problem with nocturia 2 times or more that bothers you. And in fact, probably after 4 o'clock, except for what you need to drink during dinner to keep you from being really thirsty. Dietary restrictions, caffeine at night, alcohol at night. Alcohol is a diuretic. And something a lot of people don't realize, salt restriction. If you use a salt substitute during the day, which you should use anyway if you have congestive failure or peripheral edema, that in itself is going to help. I'll show you, a very interesting slide that shows what happens if you increase your salt intake and if you decrease your salt intake. If you take a late afternoon diuretic, you should be able, hopefully, without harming the patient, to switch that to an earlier time during the day. So they just urinate more during the day, they're awake, rather than having to get up at night. Compression stockings for those who have peripheral edema. I mean, really important. You can even use the type of compression stockings that go, basically all the way up, the thigh. and afternoon and early evening leg elevation for those who have peripheral edema, just to get the interstitial fluid, back into the vascular system. And actually, the leg, the interstitial tissues of the leg, especially if you're obese, can store a tremendous amount of fluid without there being any obvious sign of significant peripheral edema. So anyone who's obese, even if they don't have much peripheral edema, it's a pretty good idea to tell them to elevate their legs for an hour, hour and a half or so, early in nighttime, to try to get that fluid off before they go to bed. It's not going to change the total times they urinate, but it will change the balance between being awake and being asleep. Medical management. Well, start with the obvious. Tightly controlled diabetes. Fix congestive failure as much as you can. Fix peripheral edema as much as you can. Try and control the hypertension as well as possible, and try and control it at night. Make sure, in fact, it does dip like it's supposed to, and that they don't have non-dipping hypertension and sleep apnea. And we'll talk about what correcting that does in a minute. So, simple logic to decrease nocturia, obviously, decrease nocturnal urine production. That's what we've been talking about. If a patient has significant residual urine volume, then improve the nocturnal storage by decreasing the residual urine volume. If you ever want to see something that's really impressive, if you take somebody that has an overactive bladder, an underactive bladder, and has a big residual urine because of that reason, and they have a problem during the day as well, but nocturia drives them nuts. If you put that patient on intermittent catheterization and make sure that one of the catheterizations is before bedtime, the nocturia will magically disappear. So that's the best example of an increased residual urine volume causing nocturia. And decreasing bladder activation on either the motor side or the sensory side of the micturition cycle, which is what you try to do to decrease the symptoms of overactive bladder or the symptoms of benign prostatic hyperplasia causing obstruction, which can cause involuntary bladder contractions. So the treatment, you pick out the most prominent symptom or set of symptoms first. As urologists, gynecologists, internists, family practitioners, you can treat overactive bladder. You can also medically treat prostatic enlargement or obstruction. If that fails, you can refer to a urologist for outlet reduction, and you can certainly begin to treat nocturnal polyuria. And that's all pretty logical. Now, unfortunately, the medications to treat lower urinary tract dysfunction in men, for nocturia at least, were not significantly better than placebo in short-term use. And that comes from years of trial and error. And here's another quote: data on overactive bladder medications generally had a female predominant population and were not significantly better than placebo for nocturia in short-term use. It's an assumption that this would apply also to male-only populations. So here's another opinion. Marcus Drake, who's one of the people worldwide that looks into nocturia, little response has been seen from anticholinergic agents, which is usually the first choice for overactive bladder, and alpha blockers, which is usually the first choice for BPH. So this is a nice chart of the effects of various anti-muscarinics, okay, the medicines you use for overactive bladder, and their effects on nocturia. Now, this is not -5 times, this is -0.5 times. Okay, so you can see that, yeah, they do have an effect, but boy, it's pretty small. That doesn't mean that you're not going to hit a home run in some patients if they really have overactive bladder. And that's what causing the nocturia. They get up and they have to run to the bathroom, or else they feel like they're going to use it or lose it rather. But you can see that none of these taken in general has a spectacular effect, although some of them are statistically significant. Whether they're clinically significant or not, you sort of have to decide. Now, this is an interesting study done by two gynecologists from Loyola. Basically, they looked at solifenacin, or Vesicare, which is an antimuscarinic, and compared that against placebo and found that, okay, in general, for all patients, that it did decrease nocturia significantly, and it was more than placebo, although there was a high placebo effect. But when they subdivided this into people that had nocturnal polyuria and those who did not, they found that the antimuscarinics were effective only in the ones that did not have nocturnal polyuria. Ray Rackley from the Cleveland Clinic looked at a number of patients and found that the greatest effect between drug and placebo in patients with nocturia treated with antimuscarinics were in those who had severe overactive bladder symptoms when they had to get up to urinate. So the conclusion basically from those two papers is that the antimuscarinics, anticholinergics, offer the most potential to patients with significant and severe nocturnal urgency without nocturnal polyuria. And the beta-3 agonists are about the same. So my feeling is if a patient has urgency when they awake at night, not just normal urge, there's no problem in trying an antimuscarinic or a beta-3 agonist, especially a short-acting one if the problem is primarily at night. And as I said, the beta-3 agonists, this is mirabegron in a study that Vic Nitti from NYU did. He's now at UCLA. This is mirabegron 50, mirabegron 100, and there's no difference statistically between placebo and the drug. But occasionally you will hit a home run. Now, I don't know how many non-urologists are familiar with posterior tibial nerve stimulation. It's pretty simple. You apply stimulation to the posterior tibial nerve and hope to decrease bladder overactivity. So this would apply to the patients mainly that had overactive bladder and nocturia. And as you can see that it is somewhat successful. Here's a review that was done 10 years ago by Ash Manga, and the mean reductions vary from very low to something that's higher. The median positive effect was 33%. And that's basically for patients that have overactive bladder. What about Botox? Well, again, it's mainly a treatment for patients that have overactive bladder and nocturia if everything else fails. And as you can see, the effect is, it's greater than placebo, but it's not startling, surprisingly enough. It's certainly not as effective on this one symptom as it is on the other symptoms of overactive bladder. The one exception is in some patients that have neurologic disease, multiple sclerosis and Parkinson's disease, and those that have multiple system atrophy. You can see that for some reason, those patients seem to have a better result with intravesical botulinum toxin than the ones who are non-neurogenic. Sacral neuromodulation, where you attach wires attached to a stimulator that's implanted to the pelvic nerves, S2 and S3. That's an operation. It's not devoid of complications. So I think In these patients, you have to have someone who's truly refractory to all medications for overactive bladder, to posterior tibial stimulation. And you can see that in those patients, basically the best results are achieved in younger patients. Here's a series where the patients went from a baseline of 3.25 to 1.42, which is pretty good. And you can see as the patients get older, for some reason, the effect is not as good as in a younger patient. And Ken Peters basically showed pretty much the same thing, is that as the patients got older, the efficacy of sacral neuromodulation became less. So basically, most therapies for overactive bladder don't really adequately address the underlying cause of nocturia in the majority of people, and that's nocturnal polyuria. That unfortunately, the improvement, except for those patients who get up with an overwhelming desire to void, the improvement may be minimal. Now, what can you do with somebody who has nocturnal polyuria in whom all the simple things have failed? Treated their congestive failure, you treated their hypertension, they have tightly controlled diabetes. I mean, you've cut down on their fluid intake. You know, maybe you've tried switching their diuretics around. Well, you go to the therapies that will decrease urine volume at night. So I think everyone is familiar with the mechanism of urine production. Usually the arginine vasopressin concentration is low. The collecting duct is not permeable to water. A large volume of urine is produced at night in those patients that have a deficient arginine vasopressin excretion at night. And this is one mechanism which you can solve without giving them a drug: sleep apnea. What happens in sleep apnea? Well, these patients generally have nocturnal polyuria. And the reason they do is because their increased airway resistance, when they obstruct their airways, that's what sleep apnea is, and they wake up, startled, and then they go right back to sleep. This causes hypoxia. Hypoxia leads to increased pulmonary vasoconstriction, which leads to increased right atrial pressure, which leads to increased production of a substance known as atrial natriuretic peptide, which decreases arginine vasopressin production. And that at night obviously increases the sodium and water excretion. So if you apply CPAP or something that's going to correct sleep apnea, basically this is kind of what you can expect. So in patients that have 2 times or more nocturia in this series, I mean, look what happened. That's a pretty spectacular result. Here's another one, pretty spectacular result. Here's another one. One of the authors of that paper that I showed you that looked at who responds and who doesn't to antimuscarinics, but again, pretty spectacular result. So that's probably the best fix that you're going to get in reducing nocturnal urine volume without a medication.
Alan, sorry to interrupt you. We actually have one other talk after you.
This is basically almost done.
Okay, thanks.
So you can give a time diuretic in the afternoon, like Lasix. You can try that to get fluid off before they go to bed. No harm in trying that. Here's one study with essentially furosemide with Lasix. If you decrease the salt intake, this is what happens when you decrease salt intake. Nocturia goes to here, the nocturnal urine production goes down. If you increase salt intake, the nocturia goes up and the nocturnal urine production goes up. Most of the urine in nocturnal polyuria is produced early at night, so it's most important to decrease things early at night. And basically, that's the rationale for giving desmopressin. It's a synthetic analog of arginine vasopressin, so it increases the osmolarity. It decreases basically the urine flow. If you're going to use desmopressin, and I'll stop here, the real question is desmopressin dangerous? Well, if desmopressin causes you to hold on to more fluid, what's the worst thing that can happen? Hyponatremia. So this was a meta-analysis about the percent of patients with hyponatremia, sodium below basically 130. When it gets to 125, it's critical. These are the risk factors: low sodium at baseline, older patients, women are more sensitive to desmopressin than men, and decreased renal function. So if you're going to give desmopressin, you need to get a baseline sodium, you need to get one in a week, and you need to get one every month and at least every 6 months. So the one compound that you can get is Nocturna. Be very careful about using it. You can add Nocturna to any of the other therapies that you use. And so what's the bottom line about Nocturia? This is the slide I showed at the beginning. Basically, we need to make sure that more people recognize Nocturia as a very troublesome standalone problem. We need to find a simple way for people to evaluate it, and hopefully another drug that's easier to use than desmopressin to reduce nocturnal polyuria. So I hope that's answered some of the questions. Thank you so much for allowing me to do this. Appreciate it.
Thank you.
Just want to see if there are any brief questions that any of the staff members might have. I know we're running a little bit late here, but just Alan, I just wanted to introduce you to all of the staff that are here. So just want to say thank you.
You guys are doing a great job, so thanks so much. And Dan, thank you for for organizing this.
Of course. Well, thank you so much for the opportunity. If it's okay, there's one other talk after you. We're trying to get everybody home for dinner time. But thank you so much, Alan. I really appreciate it.
Take care, Dan. Okay, return safe.
Thank you.
Yeah, will do.